Uh, Mine is a 66-year-old female, diabetic, hypertensive, effort angina, NYH3 on optimized medical therapy for 6 months. Wrist ECG was normal, echo, normal ejection fraction, no wall motion abnormalities. Underwent a stress echo, and that was reported as positive for inducible ischemia with mild global hypokinesia. It seemed to be to us a little non-specific finding, but she definitely had angina with ST depression in leads V1 to V6. Based on this, angiogram was done, and this is left system in ariocaudal view. We can see disease in left circumflex after major OM, some plaquing before major OM. LED essentially not showing any significant disease. It appears to be some mild to moderate grade of plaquing in the mid LED. This is again in cranial views. I'm sure everyone would be able to appreciate that extent of severity of stenosis in LED was not that great. These are frozen images of right coronary artery which appear to be significant out of all three. Mid RCA, long diffuse disease. But the picture on stress echo, the ECG showing changes, they were not correlating with RCA becoming a significant disease. So she was recommended stress thallium. Stress thallium showed that the anterolateral territory is viable and ischemic, and postero-inferior regions are entirely non-ischemic. So that put forward and clarified the issue that we need to, if at all, focus on LED only, less often on circumflex or RCA. So two non-invasive imaging modalities showing results which are not concordant with the angiographic finding. It was like a visual functional mismatch. And we thought looking into LED also, you have some plaquing between diagonal 1 and diagonal 2. There is some lesion in the mid LED distally. So ultimately we still will have to find out which lesion is significant really. And that's why we thought we will have FFR assessment and then image guided PCI. So the FFR of all three vessels were done, and LED showed FFR of 0.76. Pullback before the level of D2 showed FFR of 0.84. Circumflex FFR was 0.90 and RCA was 0.94. So it clearly showed that despite RCA showing significant disease, it was non-ischemic. LED was ischemic. Circumflex again was non-ischemic, and we had to go ahead with fixing up the LED. So based on this, we went ahead with, this was RCA, again 0.94 was the FFR. OCT pullback we took from the distal LED right up to the proximal LED. In the distal LED, we can see that mainly as we approach towards the lesion, we'll see dominantly fibrotic lesion, and it was relatively a more focal kind of disease. As you come more proximally forward and approach the D2, there were increasing degrees of fibrosis, and there were some areas where the extent of disease was not really significant. And as we approached towards D2, increasingly lipidic plaques started coming in. And then there were mixed plaques, fibrolipidic, and ahead of D2, between D1 and D2, there was spotty calcium and large lipidic plaques. Going into some of the snapshots, the mid to distal LED had EAL to AL dimension about 2.3 millimeter, and proximally little it was about 2.43 millimeter, and it was dominantly fibrotic. Coming more proximally between around D2, proximal and distal to D2, we saw that the areas were about 1.9 millimeter square at point A. More coming proximal, we saw lipid-rich plaques. Bifurcation was relatively wide open. Ostium was not showing significant disease. And there were evidences of some thin cap fibroatheromas also with large lipid plaques. Though the area were not, the luminal area here was about 2.17 millimeter square. So OCT had shown that LED between D1 and D2 had areas around 2.1 millimeter square millimeter. There were fibrocalcific lesions, lipidic plaques, and then there were thin cap fibroatheromas as well. And apart from this, we did so that there were significantly dense adventitial vasa vasorum, and there were intraplaque neovascularization, which artificially, they are also surrogate markers to say about plaque vulnerability, because more vascularity brings in more inflammatory cells, and in the event of intraplaque hemorrhage, it can lead to plaque rupture. So considering these kind of abnormalities that we saw in the segment between D1 and D2 and this kind of luminal area, we thought we'll go ahead with stenting that segment as well, despite the FFR at that point was about 0.84, but that was in presence of the distal lesion. So this is one of the articles with Kensuke Nishimi, who has done pioneering work in coronary morphology in INOCA, and he has proposed this abnormalities to look for additionally for plaque vulnerability about adventitial vasa vasorum and intraplaque neovessels. So we went ahead with stenting the vessels with appropriate sizes. In mid-LAD, we took up 2.5 to 23 millimeter stent, but we didn't deploy at nominal pressures. We remained sub-nominal, and thereafter optimized with NC balloon. And in proximal LAD, that is between D1 and D2, it took up long 3 into 48 millimeter without pre-dilatation, looking into large lipid core. And avoiding that area, we post-dilated with 3.25 NC balloons at high pressures and overlapping in the healthy area. So this is the final angiographic result that we could achieve with. And the OCT run post pullback showing good apposition and expansion. For the sake of time, I will just go through the areas here which appear to be adequate and without any areas of malapposition. And bifurcation was fine, diagonal was flowing well, no compromise. And this was post measurement of LAD FFR after stenting that showed value 0.76 going up to 0.98. So learning points are FFR in stable multivessel CAD helps choosing culprit vessel and culprit lesions. OCT guidance helps plaque morphology, guides lesion preparation. Bifurcation angle at side branch predicts probability of side branch closure. And lastly, density of adventitial vasa vasorum and intraplaque neovascularization may be additional finding to suggest plaque vulnerability. Thank you.